All right, let's go ahead and get started. We're at the top of the hour. Welcome, everyone. Thank you all for joining our fourth webinar in the Tiny Webinar series. Today, we will be hearing about alternative approaches to early respiratory management in infants born less than or equal to 23 weeks. My name is Leanne Pavlik. I am a neonatologist at Nationwide Children's Hospital in the US, and I'll be helping to moderate today's session. We have two wonderful speakers today. We have Dr. Angela Kribs, who is the head of the Department of Neonatology at the University of Cologne in Germany. She is an accomplished researcher and has extensive clinical experience in caring for these tiniest patients. Additionally, Dr. Kribs serves as the co-chair of the Tiny Baby Collaborative Steering Committee. We also have Dr. Jonathan Klein from the University of Iowa, where he recently became Professor Emeritus in June of 2023. Prior to that, he had been Professor of Pediatrics, and he served as the NICU Medical Director since 2005. Dr. Klein has been taking care of patients born at 22 weeks since 2008 and has been working with all forms of high-frequency ventilation since 1987. Joining me in moderating today's session is my colleague, Dr. Leif Nellen, also at Nationwide Children's Hospital, where he is the Division Chief of Neonatology and Professor of Pediatrics at The Ohio State University College of Medicine. Dr. Nellen's passion lies with improving outcomes of extremely preterm infants, and he was critical in developing our small baby NICU here. He is currently working to improve the outcomes of infants with the most severe forms of bronchopulmonary dysplasia. And finally, we have Dr. Charles Rohr, who is an associate professor of pediatrics and clinical director of the National Perinatal Epidemiology Unit Clinical Trials Unit at the University of Oxford and a consultant neonatologist at the University of Bristol. Dr. Rohr is a strong proponent of evidence-based neonatology with a specific interest in understanding the cardiorespiratory adaptation at birth and how to best support the newly born infant. We did briefly want to highlight one initiative that Dr. Rohr is part of. This is an international priority setting exercise that was designed to determine the most pressing research priorities for extremely preterm infants. This here is a short survey that was designed to bring together healthcare providers with families of preterm infants and the patients themselves to determine the most important necessary questions for future research. So there is a QR code on this slide, and I'll also place this link into the chat if you're interested in participating. And please feel free to share this survey with your colleagues, but also with any patients and families who you think might like to participate as well. As I mentioned, we are on webinar number 4, and we have 2 additional webinars planned for early 2024. You can see here, we are also in the works for developing a second round of webinars, since there are certainly plenty more topics to address for these patients. A couple of housekeeping items. Today's session is recorded and will be available on our website in about a week, where you can also find recordings of previous webinars. We do have multidisciplinary attendance, and this can include children and families of former preterm infants, so please be respectful. And then finally, thank you for all the great questions that we received during the sign-up form. And you can also use the chat function. And we'll have a Q&A at the end of today's talk. Here is a brief overview of who signed up for today's session. We have 62% attending neonatologists and a nice number of nurse practitioners and physician assistants, trainees and nurses, as well as some researchers, parents, and others. And we have attendees from more than 40 countries, including about 60% from the US and 10% from Canada. You may recall answering a few questions when you signed up for today's talk, and here are the results of those. We first asked, what is the first-line ventilation strategy for intubated infants who are born at 22 and 23 weeks? You can see 45% responded volume-targeted conventional mechanical ventilation. About 1/4 replied with each high-frequency jet and high-frequency oscillatory ventilation, and 9% replied with pressure control. 77% of our sites report that, yes, they use 2.0 millimeter endotracheal tubes when needed for these patients. And the inverse, only 23% replied that they use less invasive or minimally invasive surfactant therapy for these patients. With all that said, I will hand it over to Dr. Rashavi to briefly present some data to go along with today's 2 talks.
Hi, thank you, Dr. Pavlik. It's great to have you all here to talk about these important topics. Today we'd like to do something a little bit new for our group. and that is to look at center-specific data that we've been collecting. Next slide, please. One of our sort of philosophies going into this is that we have recognized that around the world, people take different approaches to the care of the most extremely preterm babies. And one way that my mentors taught me to think about this is that there can be multiple paths to the top of the same mountain. So we can achieve very high survival and low morbidity through different paths. Next slide, please. For those who are more mathematically minded, you might call this algebraic equivalence. So if you want to get to 7, there's a few different ways that you can get there. 3 plus 4, 5 plus 2, 1 plus 6. These are combinations of numbers, none of which overlap, I might point out, but they all get you to the exact same place. Also importantly, as we're going to talk about, it's in their sum that we get to 7. Next slide, please. So our Tiny Baby Collaborative, which started now several years ago, was first designed around founding sites at the University of Iowa, the University of Cologne, the University of Uppsala in Sweden, and then several collaborators in the Japanese Neonatal Research Network. The reason that these sites in particular were selected was that we organized around the fact that we had all had anecdotal experience that was very sustained of good outcomes, high survival and low morbidities for babies at 22 weeks, specifically that the majority of our patients were surviving for over half a decade. So at the outset, we decided to try to better understand what different sites were doing to achieve these outcomes. What we've learned is that they are doing some things that are somewhat different, and that's one of the things that we will talk about today. Our group has grown now. This is an evolving area of clinical practice in many parts of the world. We currently have organized a study called the MINI study, the Multi-Site Inventory of Neonatal and Perinatal Interventions. It's currently taking place at 20 plus sites in 4 countries. We have new centers joining all the time. So if anyone at your center is interested, you can reach out to us via our website and communicate that. We can talk about the particulars. What makes us unique is that we collect information on all births in addition to NICU admissions. And then we collect data specifically at 22 and 23 weeks. In some parts of the world, there are some 21-week babies being admitted to the NICU. What I'm going to show today are our baseline data for 4 years, from 2019 through 2022. Next slide. So I'd like to highlight that our speakers, Dr. Klein from the University of Iowa and Dr. Kribs from the University of Cologne, both have led units here with extraordinary world-class rates of survival. I'm showing here the number of babies of those who were live born, who were actively treated in the first rows. And then below that, the rates of survival amongst live born babies. So including those who were not actively treated, who we know all passed away. And you can see it's a majority at 22 weeks and 75–80% at 23 weeks. These are not statistically different, by the way. I would like to put that in comparison to average US statistics, where about 20% of 22-week babies survive and 50% of 23-week babies survive. So these are very high rates of survival. Next slide. But it's interesting when we start to look at practices to see how some of the differences bear out. So the approach that Dr. Klein is going to discuss today involves intubating 100% of babies within the first hour. At the University of Cologne, you really see a very different extreme, 8%. 100% of babies, of course, are intubated at admission at 22 or 23 weeks, and 79% are ever intubated. That is 20%, 21% of babies at the University of Cologne during this period were never intubated at 22 or 23 weeks. Um, Babies are intubated within the first hour at the University of Iowa. The average in Cologne was around 110 hours or 4.5 days in this population. So the most babies getting intubated, but a few days later after birth. You can see here the duration of ventilation. You can also see the number of reintubations, the proportion of babies rather that were reintubated, which is about the same. Next slide, please. Here we show some relevant respiratory morbidity measures. So the rate of pneumothorax, very similar, very low at both sites. The rate of what might be called grade 3 BPD, extremely low at both sites in the 1 or 2 patients of these cohorts. 0% tracheostomy, and then different uses of nasal cannula at discharge. So that may not be just a reflection of lung health. There are multiple reasons that people would do that. So I think we should be cautious in interpreting it as such. Next slide, please. Very similar rates of IVH. There's a little bit of a difference in ROP here. That's changed over the years, as Dr. Klein, I believe, will show at the University of Iowa. Also some difference here going the other direction in terms of surgical bowel pathology, meaning that there was a drain or a laparotomy. PDA management is notably similar in that echoes are performed within 24 hours. Targeted treatment is given, so the majority of babies are treated for a PDA medically, but the rates of surgical or catheter closure are quite different. And that may reflect, different exposures of the respiratory system to inflammation, duration of mechanical ventilation, but there are other potential explanations for this. Next slide, please. One thing that I hope that all of you take away from today's talk is not to isolate any particular practice. As one of my teachers taught me, you cannot plant an orchid in a cornfield and expect it to grow. So don't try to listen to one of the speakers and just take one idea to your site. Both of these speakers are going to be talking about an ecosystem perspective, and it's really a whole bundle of processes and procedures that they will say themselves have allowed them to achieve these great outcomes. Next slide. And so with that, I'd like to give the floor here to Dr. Klein from Iowa, and then Dr. Kribs will follow up. We'll have about 20 minutes for discussion at the end. Thank you.
So I'm going to talk about an alternative approach that we use at Iowa, which is first intention high frequency jet ventilation. And I have nothing to disclose other than that we've now engaged in the care of 21 weekers. This is one of the 21 weekers, first intention jet, who is home, and the other two, one should be going home within the next few weeks. I also want to expand on the outcomes because, to me, I like as large as numbers as possible. And so that if we look at the survival over a larger period of time rather than 19 to 22, but 06 to 2022, you could see survival 60% of 79 live-born infants, 77% of 124 live-born infants, and 85% of 24 weeks of 126 live-born infants. The other thing that's important is also neurodevelopmental outcomes. So if we look at neurodevelopmental outcomes at 18 to 22 months of corrected age for 22 to 23 weekers, we found 62% had basically no or mild, and only 11% had severe. So the primary objectives for this talk is to look at the impact of antenatal steroids on fetal lung development, look at the importance of fetal lung development on ventilator strategies, identify strategies for babies under 24 weeks using low tidal volume ventilation to reduce shear force injury, and importantly, air trapping with first intention jet ventilation, describe a few other supportive strategies, and review pulmonary outcomes when using first intention. Antenatal glucocorticoids are critical for survival by accelerating fetal lung maturity. It increases survival from 18% to 39% for infants born at 22 weeks, increases survival from 36% to 54% for infants born at both 22 and 23 weeks, It accelerates differentiation of type 1 and type 2 alveolar cells, thinning the mesenchyme and alveolar septa, increasing invasion of capillaries into air spaces, improving both oxygen transfer and gas exchange. So obviously we want antenatal steroids for this population. So how can effective gas exchange occur before alveolar development? And the important thing to realize is that there's a great overlap between the canalicular and saccular stage of lung development. Someone might need to mute their mic. And between the, so it's not a straight line like here, right at 24 weeks. So there's overlap, obviously, from 22 weeks onward. And this is clearly seen in rat animal models that show for a 22-day rat, but the canalicular and saccular stage do overlap. So we know that we have the terminal bronchioles go to respiratory bronchioles, go to alveolar ducts, and you get termination into alveolar sacs. And you have to have the alveolar sac, which is thin walled and vascularized for gas exchange. Normally that begins at 24 to 27 weeks, but importantly, the lung doesn't mature in a homogeneous fashion. So cranial segments mature faster than caudal segments. So areas exist within the fetal lung mature enough for gas exchange to occur, allowing for survival even before 24 weeks. So two major points for this to occur. One is we must focus on minimizing mechanical injury, which is the volutrauma shear force injury, to these youngs using a lung protective strategy to minimize PIE at the canalicular stage of lung development, and exposure to antenatal steroids to enhance fetal lung maturation. PIE prevention is very critical for this population. We know PIE is a collection of gases outside the conducting and gas exchanging areas, which obstructs both pulmonary blood flow and ventilation, often develops within 48 hours, has high mortality and morbidity, obviously associated with the earlier the chronological age, lower birth weight, and lower gestational age. And in the pre-surfactant era, mortality for VLBW infants was more than 60% if you allowed conventional peak pressures to reach any above 25 anytime during the first 2 weeks of life. Now, this is unfortunately a patient that was transferred to us, basically had end stage PIE, was sent to us because of no renal blood flow, obviously because of no cardiac output. We were able to correct the PIE issue, but unfortunately, many weeks later, the head imaging showed severe cystic PVL, so that was redirection of care. So the data showed that first intention did reduce the incidence of BPD from 40% to 20% in infants with RDS treated with surfactant. It's important that we want to avoid PIE because there's an impact of air leaks, and we want to avoid hyperinflation of pulmonary vascular resistance. So we know alveolar compression from external forces, pneumothorax of PIE, or internal forces, atelectasis and surfactant deficiency increases PVR, which worsens oxygenation and VQ mismatch, and external compression decreases preload, worsening cardiac output, leading to poor neurological outcomes. We also know that hyperinflation, intraalveolar overdistension, increases PVR, worsens oxygenation, worsens VQ mismatch. And importantly, hyperinflation also decreases preload from inadequate venous return, worsening oxygen delivery, decreasing cardiac output, and impacting cerebral blood flow. In the delivery room, our approach, this is for 22 and 23 weekers and 21 weekers, is we initiate resuscitation with 50% oxygen. We titrate per goals to minimize hypoxia and hyperoxia. We know if you don't reach 80% by 5 minutes of life, it's associated with greater risk of death or major neurodevelopmental disability. When starting with 50%, we know from that mortality below 28 weeks, if you start with room air, is 22%. Now, it's with 100%, it's as low as 6%. There is an RCT going on right now, starting with 100%, but right now we wouldn't recommend that. We stick with 50% and then titrate. We do intubate electively with 202s for 22 weekers, 2025 for 23. And a study recently from 2022 showed at birth invasive, so intubation electively in this population compared to trial of non-invasive respiratory support in this population in the delivery room reduces severe IVH and death for 22 to 23 weekers by twofold. It's important that the ET tube is not main stemmed. We transfer the NICU with general bagging focused on heart rate and saturations, and we use a PEEP of 5. Now, our main concern is not getting hyperinflated. And we know from the SAIL trial, a significant increase in early death occurs in the sustained inflation group, 7.4% versus 1.4% in the controls, with 11 out of the 16 SAIL deaths occurring in the 23 to 24 week group. So we feel in this group, it's very important to avoid this hyperinflation and impact on cardiac output. Our recruitment strategy obviously is the surfactant to reduce the surface tension. So we start within less than 10 minutes of life on the jet. We give surfactant as soon as we can confirm the ET tube is not right main stem, which often happens in these tiny babies. 2O tubes, the only issue is we know resistance to flow goes up the radius to the fourth power. So the peak pressure in the jet to deliver the same effective tidal volume tends to run a little bit higher in the mid 20s versus the low 20s with the 2.5. Importantly, there was no difficulty in maintaining effective ventilation oxygenation with the 2O tube, and there's 77% survival with 2O tubes. So it's not a marker of fetal lung immaturity. The jet works as a flow interrupter with a Peach valve to generate a stream of high frequency pulses, which is the tidal volume. Gas is injected at high velocity, producing flow streaming, sending gas via laminar transitional flow down the core of the bronchial tree, minimizing the effect of dead space. So you can ventilate with tidal volumes below 3 per kilo, often below 1 kilo. You need a conventional ventilator run in tandem, however, to generate the PEEP and side breaths if needed. The important point is exhalation is passive from elastic recoil. It's not active like an oscillator, so the approach has to be different. So the approach for first intention for RDS in the sub 24-week population is starter rate of 300. This is an IE ratio of 1 to 9. At a lower rate, more time is spent exhalation with a fixed I time, which decreases air trapping from passive elastic recoil. This air trapping is where neonatologists get into trouble. The rate, however, can be increased as the lung begins to develop to improve with oxygenation and ventilation. We keep the I time fixed at 20 milliseconds. Our goal, again, is to avoid PIE, hyperinflation, overdistension, and obviously avoid hypocarbia. The initial PIP, as we talked about, would be low 20s with the 2.5 and middle 20s with the 2.0. And again, the initial PEEP, and we're now in an era of antenatal steroids and approved surfactant. So we started 5 to avoid the hyperinflation right away. Our goal was to avoid impeding venous return from hyperinflation, neuroprotection, and to avoid mechanical injury to the lung from hyperinflation. One of the other unusual things is that we will consider repeat surfactant therapy for post-surfactant slump. We know 20% of babies under 1,000 grams develop this after day of life 6. You can see respiratory index goes up almost twofold. 63 to 70% of infants will improve in severity of their disease with treatment, but importantly, the treatment takes 12 to 24 hours to kick in. Two or more doses predicts it, and antenatal steroids helps reduce it. Either surfactant works quite well with this. Importantly, we've shown that you have to make sure the problem isn't due to a large hemodynamic significant PDA. So if there's a large shunt, you need to address the shunt. As that's being addressed, if the patient is not getting better, then we'll give this surfactant. You also need a standard approach to extubation for babies born before 24 weeks. We know that failure in the first 2 weeks of life, usually in babies less than 26 weeks, is associated with increased death before discharge, 28 versus 6%, as well as worse BPD, late onset sepsis, severe IVH. Another study showed if you fail, again, in the first 12 days of life under less than 26 weeks, even after 3 days of ventilation, you're still behind. And the APEX cohort showed early failure before 8 days of life had a greater risk of death, again, in primarily babies less than 26 weeks. And the APEX cohort had no 22-weekers and 100% failure rate at 23 weeks. So we extubate when we know they have a higher chance of success, and we always extubate directly to non-invasive ventilation. So for infants born before 24 weeks, should we use a different marker for pulmonary outcomes? So old BPD, oxidative mechanical injury resulting in large lung cysts with progressive interstitial and alveolar septal fibrosis, areas of atelectasis alternating with hyperinflation. You know, this is the group that it does make sense. We should reduce the need for high oxygen at 36 weeks. New BPD is a different group. You have disruption of lung development with arrest of alveolar septation and vascular development leading to alveolar simplification. So if you're managing infants born at the canalicular stage of lung development, we focus on the 21st century clinical definition from Eric Jensen, invasive mechanical ventilation at 36 weeks. So the 20th century definition, supplemental oxygen. So our pulmonary goals, number one is the work from Al and Joe, which doesn't get paid enough attention to, which is we don't want lethal BPD. This is grade 3A. This is death from respiratory failure from any cause before 36 weeks PMA. And from Eric Jensen's work, we know if we reduce grade 3 BPD, invasive respiratory support at 36 weeks, we will reduce moderate to severe neurodevelopmental impairment. as well as late death and serious respiratory morbidity like tracheostomy. So our respiratory outcomes for infants treated with first intention high frequency in this group, we had 70% survival in this cohort of 22 weekers, 82% of this cohort of 23 weekers. Median duration of ventilation is 63 days, which is long. But if you look at post-menstrual age, more than a quarter were off the vent by 29 weeks post-menstrual age, and more than half were off the vent by 31 weeks. This interesting is 31 weeks post-menstrual age is the same what was found in the APEX cohort for infants extubated at more than 35 days of life, and they had no 22 weekers in that cohort. So in a population that's 1 week more premature, we achieved the same as these great APEX centers. Looking at grade 3 BPD, invasive ventilation at 36 weeks, in the publication, it was 6% from 06 to 2015. It's gone up a little bit. It's 9% from 2016 to 2022. The main issue is we're getting a lot more referrals of babies that ruptured before 20 weeks. Importantly, the need for tracheostomy. So this is looking at our entire history of 22 and 23 weekers. We've only had 3 out of 195 infants, which is 1.5% instance of tracheostomy, and one of them was born with multi-drug resistant E. coli sepsis at birth. The next thing is the thing about this grade 3 BPD, which is death, grade 3A, which is death from respiratory causes. If you look at the proportion of deaths due to respiratory cause for inborn 22-week infants at Iowa on first intention JET, and respiratory causes based on the paper by Sunny Jewell published in 2022 would be RDS, first 2 weeks, late respiratory failure, ongoing respiratory compromise after 2 weeks of life, or pulmonary hemorrhage. At Iowa, the first intention JET approach, respiratory causes are only responsible for 8% of the deaths of infants born to 22 weeks. In contrast, the leading cause of death in the PEANUT trial, 19 US sites, 941 infants, no 22 or 23 weekers. Respiratory causes were responsible for 60% of all deaths at 24 weeks and 50% at 25 weeks. So you can see on this graph, here are the respiratory causes responsible for 60% of all deaths at 24 weeks in that population versus our 8% of deaths in a first intention JET approach. Non-pulmonary morbidities are critically important. So if we look at 22 weekers, the severe IVH in that group was 23%, PVL 6, BP shunt 3%, neck incidence 12, RRP requiring laser therapy was 9%, and that was over a large period of time. So in summary, lungs at the canalicular stage are at a high risk of mechanical injury. Keys to intact survival include antenatal steroids, minimizing value trauma with low tidal volume ventilation, and extubating for success, not failure, when developmentally appropriate. First intention JET, even with a 2.0 tube, is effective in managing infants born before 24 weeks. And it's possible to ventilate infants born before 24 weeks with the JET with high survival over a long period of time, 60% at 22, 77% at 23, with low rates of, I would say, grade 3 BPD, grade 3A BPD, and tracheostomy. Thank you.
Oh, now I want to present our approach, the colonial approach to the early respiratory management of extremely preterm infants. These are my possible conflicts of interest that certainly have not influenced the content of this talk. We have a certain philosophy behind our respiratory care for the extremely preterm infants. Our clinical observation is that most preterm infants and also the extremely preterm infants with a gestational age below 24 weeks start spontaneous breathing after birth. They are not dead, and therefore they do certainly not need resuscitation, and they certainly need support during the transition. Because if we observe them, then we see that the rhythm of breathing can easily be disturbed. And they also often show signs of dyspnea and respiratory distress. So our questions are, what can we do to help the infants to start spontaneous breathing and to preserve respiratory function? And what are the causes of dyspnea? And what can we do to avoid and to treat this dyspnea? We are also sure that close cooperation with the obstetricians, the anesthesiologists, and the midwives is a cornerstone of improvement of outcome of preterm infants, and the antenatal periods have an outstanding importance to preserve the life of these infants. So we have to cooperate with obstetricians that we only get babies with full courses of antenatal steroids. But it is also of high importance to avoid asphyxia and inflammation, and to avoid depression of spontaneous breathing of the infant by use of general anesthesia in the mothers. So we have to have an optimization of the anesthesia for the mother, and an optimization of birth mode, and a very important thing is optimization of umbilical cord management, and we are convinced that a certain kind of physiological-based cord clamping is very important. And we have standardized our delivery room management, including optimization of temperature, and this includes heated and humidified gas from the early beginning. We minimize any kind of stress to not disturb the baby in its own attempts to breathe. We have a strategy for lung recruitment. We use very early surfactant in the delivery room, and we use early coffee. And to our opinion, establishing of stable respiration means creating a balance between oxygen consumption and oxygen intake. We can do a lot of things to improve oxygen intake by giving oxygen, CPAP, or mechanical ventilation, but we can only also do a lot of things to reduce oxygen consumption by avoiding any stress for the baby, by improving temperature management, but also by reducing light, noise, pain for the baby, the loss of postural control, and to minimize the duration of separation from the mother. And if we reduce the stress for the baby, we will observe that nearly every baby starts breathing during the first minutes after birth. And we know from the term babies that they have specific patterns to reach lung recruitment after birth. They have an end expiratory halt, and during this time, the air goes from proximal to distal, and the fluid in the alveoli goes to the interstitium. The preterm babies try to do the same thing, but they have some specific characteristic of the respiratory system that makes it difficult for them to do this special patterns of breathing after birth. They have unstable upper airways, they have stiff alveoli with a reduced surface area, a thick interstitial tissue, and they have an unstable thoracic wall with weak muscles and the impossibility to create active sieving of the chest wall. And the application of a continuous distending pressure seems to be an ideal way to help the extremely premature baby to overcome these problems, because the continuous distending pressure realizes stabilization of airways, stabilization of the thoracic wall, and that reduces the work of breathing. It increases the intraalveolar pressure with a reduction of the intraalveolar fluid, avoidance of the end expiratory alveolar collapse, thereby preservation of surfactant and stimulation of breathing. And the question is, what is the right level of the continuous distending pressure. And to our opinion, it's very important to keep in mind that after birth, there are different phases of respiratory transition. If the baby is born, in general, the alveoli are filled with fluid. And during the first recruitment breathing attempts of the babies, the fluid is moved into the lung tissue, but at the end of expiration, it can go back into the alveoli. During the second phase of lung clearance, this may be the biggest problem, that the fluid from the lung tissue goes back into the alveoli. And at the end, the alveoli should be cleared from fluid, and also the lung tissue should be cleared. It is clear that in each of these phases, a different level of continuous distending pressure will be necessary to support the baby in its own attempt to recruit the lung. During the first phase, gas exchange is not yet possible. The fluid has to be replaced in the airways and the alveoli by air, and the fluid-air interface has to move until total transfer into the interstitial tissue. The aim during this phase is to reach a uniform aeration of the lung by opening of the glottis and deep inspirations. The duration of this phase is very short it's very short in healthy term infants, but it may be longer and lasting more than minutes in preterm babies. The therapeutic options in this period are, on the one hand, sustained inflations with long inspirations, but on the other hand, if the baby has spontaneous attempts to breathe, an increase in the distending pressure with small tidal volumes until the whole lung is aerated. The most important therapeutic element in this phase is application of a continuous distending pressure. During phase 2, the avoidance of re-entry of fluid into the airways is absolutely of high importance to preserve the aeration of the lung. The duration in healthy term newborns is 4 to 6 hours, but it takes much longer in preterm infants. Therapeutic options in this phase are also application of the continuous distending pressure, but also of oxygen, and at the end of this phase, surfactant should perhaps be applied. And during the phase 3, it's very important to maintain the FRC and blood gas homeostasis. There's an overlap between phase 2 and 3, and we have to titrate and to adopt CDP and FiO2 continuum. The question is, what is optimal distending pressure for the actual situation of the infant? And Peter Dagerville and David Fingal described that it is possible by stepwise increasing and after that decreasing of positive and expiratory pressure during conventional ventilation, or the distending pressure during HFO2, to identify the upper and lower deflection point of the pressure volume curve. And the ideal distending pressure is the pressure a little bit above the upper deflection point of the pressure volume curve.
Angela.
From a clinical point of view, the optimal distending pressure is characterized by the fact that the FiO2 is lowest and that dyspnea of the baby is also lowest. So, to realize the lung recruitment of the extremely preterm babies with spontaneous breathing and with supporting of spontaneous breathing, we use very special device. This is Benveniste valve, and this is a kind of a jet system that supports spontaneous breathing. This is a small device, and you see the direction of the flow. And the idea behind this device is that the flow goes also the easiest way. So if the baby is breathing during inspiration, the whole flow goes to the infant and enables very easy inspiration. During expiration, the flow is directed away from the infant, and so expiration is very easy for the infant. The resulting distending pressure only depends on the flow. And we use this device during the earliest phase of stabilization in the delivery room with a face mask. And after some minutes, we go to a nasopharyngeal tube, but we still use this device. And here you see the dependence of pressure in the collecting tube depending on the flow in the jet tube. And you see that with flows of 22 to 24 liters, we reach pressures of 18 to 20 liters. And we have a dedicated algorithm to stabilize the baby in the delivery room. And we use this algorithm down to the infants of 22 weeks. We start with a flow of 14 to 60 liters, resulting in a PEEP of 8 centimeters of water seal. And we observe the bracing efforts of the infant and the heart rate and the saturation. And if the baby does not breathe sufficiently, we increase the flow up to 2 to 3 times, reaching a flow of 22 liters and a pressure of about 20 centimeters of water seal. And if the baby is stable breathing and has a stable saturation above 85%, and we could reduce the FiO2 down to room air, then we reduce step by step the flow. And at the end, if the baby is stable and we cannot further reduce flow or FiO2, then we stop and evaluate whether the baby should receive sulfate. Our aim is to reach a reduction of CDP below 15 centimeters of water soil at the end of stabilization, and to reach a further reduction during the next 8 hours below 10 centimeters of water seal. If the baby is transferred to the ward, we change from the Benveniste valve to the MediJet CPAP generator. It is very similar to the Benveniste valve. It is integrated here, and we have a possibility to measure the pressure in this device. And here you see a baby of 22 weeks on the MediJet CPAP generator with a nasopharyngeal tube and a noise protection device, so that the baby can breathe comfortable and is not disturbed by the noise of the flow. We compared our results or the pressures that we applied during stabilization with in a matched pair analysis of another clinic who has another algorithm to stabilize the infant, and you see that we use during the first phase of lung fluid clearance very high pressure levels, but this results in more favorable ratios of SpO2 to FiO2, And the high pressure strategy went along with a lower intubation rate during the course of RDS and during the whole hospital stay. But certainly also with this algorithm to stabilize the infant and to support transition from intrauterine to extrauterine life, there is the risk of CPAP failure, and as CPAP failure is related to high mortality and morbidity, any thing that can help to avoid CPAP failure is of high importance. And to decrease the risk of CPAP failure, we use the LISA approach. And we use it already in the delivery room, usually after stabilization with about 30 to 45 minutes. And surfactant via a thin catheter, the so-called LISA approach, is now acknowledged as a possible approach to give surfactant in preterm infants, and it is related to a lower rate of death or BPD, intubation during the first 72 hours, severe IVH, death, and BPD in survivors. And we could show in our collective that about 75% of 22-weekers and 80% of 23-weekers are eligible to receive surfactant via this approach. We also try to improve breathing and the recruitment breaths of the babies by applying caffeine already in the delivery room after insertion of a peripheral venous line. At the age of 10 to 15 minutes, the babies all receive a bolus of 20 milligrams per kilogram caffeine citrate. And in this work, also by the Leiden group, it could be shown that early use of caffeine is related to more recruitment breathings and higher minute volume of the infants. And to our experience, it's also favorable in supporting the most extremely preterm infants to breathe. And if the CPAP support via the Ben-Minister valve or the Medijet generator is not enough, then we go to nasal high-frequency oscillatory ventilation. The idea behind this is that pharyngeal oscillations produced by bubble CPAP are some to improve CO2 elimination, and pulmonary oscillations during invasive HFO2 are known to improve CO2 elimination, and non-invasive HFO2 may be an increased bubble CPAP with the effects observed also in invasive HFO2. And it has been already shown in a meta-analysis that nasal high-frequency oscillatory ventilation is superior to continuous positive airway pressure as primary respiratory support concerning the outcome intubation in preterm infants. And in our experience, this is also the case for the most extreme preterm infants. What are the practical aspects? How do we start? With which parameters do we start nasal high-frequency oscillatory ventilation? We start with a CPAP level of 2 centimeters of water seal above the CPAP level before starting NFO-reach. We use a frequency of almost 8 Hertz. Sometimes we go down, sometimes we go also a little bit higher. And the amplitude is adopted so that we see visible vibrations of the chest. We use as interfaces in first approach the nasopharyngeal tube, but during the following days and weeks, we change between nasal bronch, nasal mask, and also nasopharyngeal tube. And we have observed that we have to respect a special effect of our respiratory management also on the pulmonary perfusion. The rapid and homogeneous aeration of the lung goes along with a decrease of pulmonary vascular resistance, and this induces a risk of left-to-right shunting via the duct very early in life. At the same time, we have a lower endothoracic pressure than in infants on invasive mechanical ventilation, and this increases the risk of early left-to-right shunt via the duct. So, therefore, we do a systematic echocardiographic screening starting at 12 hours after birth, and we do a medical closing of the duct as early as in continuous left-to-right shunting is observed. So, our key elements of our approach of early respiratory management in these very tiny babies is the use of antenatal steroids after parental counseling from 22 weeks of gestation, cesarean deliveries with local anesthesia as preferred mode of delivery, delayed cord clamping or physiological-based cord clamping by extrauterine placental perfusion, soft landing with comfort and lateral positioning of the infant, establishment of spontaneous breathing via stepwise increasing continuous distending pressure by use of a variable flow device, Benveniste valve, less invasive surfactant application early in the course of RDS, usually about 30 minutes after birth, early use of caffeine already in the delivery room, escalation to NHFV in cases of respiratory insufficiency, early screening for PDR, early targeted medical closure of duct. And the focus of our approach is establishing and preserving of spontaneous breathing by minimizing stress and individualizing respiratory support. The primary respiratory support is use of continuous distending pressure adapted to the three-phase process of pulmonary transition by individualized titration. Infant comfort is a priority during the whole process as it minimizes oxygen consumption. Caffeine is given soon after birth to stimulate spontaneous breathing. Early, less invasive surfactant therapy is a cornerstone of our approach. NFOV is preferred mode to escalate respiratory support, and early targeted medical closure of PDR is performed based on early screening. And more than 75% of infants with 22 and 23 weeks can successfully be managed with this protocol.
Thank you very much. I've asked my first question to Dr. Klein, but maybe Dr. Nellen wants to ask a question too.
So thinking a little bit about what Charles was talking about in terms of the ecosystem, I wonder, Jonathan and Angela, how did you start this? I mean, you have really nice respiratory algorithms, but they were probably different from what you're doing before. How did you get people to buy into it, and how did you move forward with this system?
Dr. Kribs should go first.
I go first, yes. This has a history, and I went more than 25 years ago to Copenhagen, where I saw the Benveniste valve. And I observed that in Denmark, nearly every infant was managed with this valve, and therefore I bought one and took it with me to Cologne. And then we started to use it in the delivery room. And our observation was that the babies were very comfortable with it. And we started first to do it in more mature preterm infants. And then we went down to the extremely preterm infants. And the observation was that the babies started breathing, that they were comfortable, but also that the most immature infants needed higher flows and higher pressures than the a little bit more mature infants. And by observing it, we formed our algorithm. And we went away from positive pressure ventilation in the delivery room and saw that nearly every infant can be stimulated to breathe. And we are convinced that the best is the baby does itself.
So thank you for that answer. In the interest of time, Dr. Klein, do you want to add something?
Briefly, since I had trained with high frequency during fellowship, when Dr. Bell recruited me to Iowa, there had been concern about the BPD unit that was growing in size. And so I said, if we, as a group, decide to do a first intention high frequency approach to minimize value trauma, this will help to eliminate that. So after 2 years, from 1990 to 92, switching to first intention, the BPD unit of 12 beds was able to close. So reduce the severity of BPD. And slowly we advanced this first intention approach as we decided to resuscitate 23 weekers in the 90s and then 22 weekers in the 2000s. Mainly we got everyone this, it was sort of inculcated into everyone that we wanted to take this approach. I do want to point out an interesting common thing between both us and Dr. Kribs is the use of the nasopharyngeal tube for non-invasive ventilation. So, I mean, we've done research on high frequency non-invasive ventilation through the NP tube, but we do our non-invasive ventilation with NABA through an NP tube. And we think that is really the best interface for achieving effective ventilation in a non-invasive manner. So it's nice to see that common thing. Plus, the extreme importance of antenatal steroids, which both centers are focused on.
Thank you. Thank you for that. Well, there is a lot of questions in the chat, and there's, apart from the technical questions with regard fixing tubes, etc., there's a specific question for Angela on how you treat the duct if you find one, and how early.
For me, the question, yes.
Yes.
We treat the duct as early as it is needed, but often it's needed already during the first day of life, sometimes after 2 or 3 days. We do it as early, we have a continuous left to right shunting. And we do it for the first 24 hours with indomethacin and after the first 24 hours with ibuprofen, according to the guidelines. We are very early. We are very early. It's early targeted, but not prophylactically, because we do it not in every infant.
I just want to go ahead and point out that this is basically the same approach at Iowa regarding the duct, that we look for it early. Interestingly, almost 40% of some of our babies, because of the prolonged rupture of membranes, actually have pulmonary hypertension on the first echo, and we also do not do prophylactic indomethacin. And when the duct switches the QP/QS and is flooding the lungs, it tends to be around day 2 to 4. And in our case, we will do acetaminophen, and if that doesn't work, then we would switch to indomethacin. But it's, again, to me, the more interesting things are the things that Dr. Kribs and that we at Iowa that we do that are quite similar.
I wonder, there's a question in the chat about sort of reflecting on the degree that reducing practice variability may be contributing to your favorable outcomes. And I think that would be an important one to think about. And I wonder, Angela and Jonathan, if you could comment on the idea with this specialized group of physicians and nurses who take care of the population, how that impacts on the favorable outcomes that you have.
I think it has a high influence, and the very tiniest babies have to become something like normality in the ward, so that every nurse and every doctor is used to treat them. If someone is afraid of doing it, or someone is hoping to do it for one time, for one single time, then that is a problem. It has to become normality. And I think this is very important.
And again, that's the same thing. I mean, we've been preaching that for a long time, that there has to be a standardized approach to this, and you have to develop a lot of experience. So we again don't have all 300 nurses caring for these babies at birth. We have roughly 50. We don't even have all the faculty caring at birth, but there are challenges as you know, when you get, if you get a large influx of new faculty, sometimes it becomes a little rough to get people back on the same approach. So there are, you know, potentially 12-month periods where you can see sort of some things kind of entropy going up, and you have to put a huge amount of energy into a system to prevent entropy. So it is constantly a lot of pressure to keep things well organized and not deviate from the standard approach.
Dr. Klein, may I dip in here? And again, many questions with regards to the ventilator management, but Dr. Kribs spoke a lot about lung recruitment and the natural physiological way, whereas Iowa tries to give mechanical ventilation after 10 minutes. Can you speak about your very initial management, delayed cord clamping?
So actually, it's not. Yeah, I'm sorry. So
that's it.
We do delayed cord clamping, but as we all know, if the baby is not breathing, the delayed cord clamping does not do anything. We don't have the ability to do like the trolleys that I've seen in some other countries, where they can start, you know, ventilation of the infant while the cord's still attached to the placenta. We do basically, we don't wait 10 minutes to intubate. We intubate within about 30 to 60 seconds. So basically it's elective intubation because we want to get this baby transitioning as soon as possible, get them oxygenating by sats in the 80s by 80%, reduce the CO2 to improve the cardiac output. Our major goal is to have improved cardiac output during this transition. So, you know, looking at the data published out of University of Alabama, that seems to be a pretty important point. And again, we resuscitate, if the parents wish us, we resuscitate, like I said, over 93% of the 22 weekers. So a lot of them are quite sick, and we've got to get that PVR down as soon as possible.
Angela, would you like to comment on initial management? I know Cologne is very specific in what they do.
Yes, we have discussed with our obstetricians, and we get the baby together with the placenta from the obstetricians, and so we have the possibility to do lung recruitment during we have the placenta still with the infant, and this is also a kind of physiological based cord clamping, because if the lung or if the baby starts breathing and the lung is aerated, there is still a flow from the placenta. And we also did a study on it, and we observed that compared to delayed cord clamping, the improvement of heart rate and of oxygenation was better in the infants who received this approach. And this might be a possibility if you have no trolley to do a kind of physiological based cord clamping.
Great. I think in the interest of time, we are about done for today, but thank you all very much for sharing your experience and your expertise with everyone. There are lots of great questions still in the chat, so I think we certainly will continue these discussions and hopefully have some future sessions to keep answering these questions and sharing our practices and our research. And thank you everyone for being patient with our technology issues for the day. Have a great day, everyone.
Thank you very much for having us. Thank you very much to the speakers.